Welcome to today's event, 3 tips for selecting the right ICD-10 encoder for the ED. Today's session will review the pitfalls of common encoder types, specific qualities to avoid in an encoder, and specific features that you should look for. My name is Kristen Monsi. I'm T-Systems Marketing Specialist, and in just a moment we'll be joined by our presenter. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we'll follow up with you in an email one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording of this event to all attendees. Leading our discussion today is Elizabeth Morgenroth, Revenue Cycle Analyst at T-System Inc. In her current position, she is responsible for encoder tool development and ICD-10 readiness for T-System Revenue Cycle Solutions. Morgenroth attended the American Health Information Management Association, also known as AHIMA, Academy for ICD-10-CM and ICD-10-PCS, and is an AHIMA-approved trainer for both ICD-10-CM and ICD-10-PCS. And now to kick off our presentation is Elizabeth Morgenroth.
Good morning, everyone, or good afternoon, depending upon where you're calling in from. I'm pleased to spend a little bit of time with you today, and thank you for sharing your time with me today. We're going to be talking about some tips for selecting encoders for emergency medicine. First of all, I'd like to say that emergency medicine, I have coded family medicine for about 5 years prior to coming to T-System. And I've always felt like emergency medicine is primary care on steroids. We take care of everything that walks through the door and then some. And so we cover the entire diagnosis spectrum, if you will. So choosing an encoder is extremely important and a prudent choice for any emergency medicine coder. So a quick review of our agenda. The first thing we're going to talk about is what is new in ICD-10-CM as it compares to ICD-9. We're not going to do any coding training, but understanding those differences kind of helps you understand why an encoder product might be a good idea. And then we'll cover the 3 tips for selecting the right encoder, which talks about the pitfalls of some of the common encoders out there on the market today, some qualities that you want to avoid, and what you want to look for if you're in the market for purchasing encoder or changing the encoder that you have. So one of the things that is new for ICD-10-CM is the addition of a 7th character. In ICD-9-CM, we had a maximum of 5 digits. If anybody's been paying attention to ICD-10-CM, we realized that that has been expanded to 7 characters, alphanumeric characters, and that 7th character, or the last character, if it's applicable to a code, can indicate the episode of care, and it can indicate the fetus if there's a multiple gestation. It can indicate that there is an open or closed fracture, and if it's an open fracture, it indicates the Gastio class, if that's applicable. And if you haven't checked out what the Gastio class is, what it is the Gastio class indicates the severity of a wound that's caused by an open fracture. And then it also indicates part of that episode of care is whether or not it's healing well, if it's a routine visit, a follow-up visit for an injury, or if it's a sequela, that means a complication. So here's some examples of 7 characters from the ICD-10-CM code set. The first one I have here is S42.322B. That is a displaced transverse fracture of the shaft of the humerus on the left arm. And that B indicates that it's active treatment or initial treatment. The B will say initial encounter, but what it really does mean is active treatment for an open fracture. If it were A, it would be active treatment or initial encounter for a closed fracture. The other example that I put up here is not an alpha character, but a numeric character that is indicating the fetus with an obstetrical code. So it's saying it's term delivery with preterm labor, third trimester, and that 0 on the end indicates it's either the single fetus or it's unspecified fetus if it's a multiple gestation. And if you look in the tabular listing, it'll say it's not applicable for unspecified fetus, and it's not applicable if it's a single fetus. Another thing that's new for ICD-10 is because of that 7th digit that indicates the episode of care or the fetus, that 7th character has to be in the 7th placeholder or the 7th position of the code. So, and the reason for that is the ability that ICD-10 has built in to expand the code set, which was one of the downfalls of ICD-9. You can't expand it to accommodate advances in medicine. ICD-10 has the ability to be expanded to add further definition or further specificity as we learn more about conditions and morbidity and mortality. And this way we don't take codes out of sequence to add that information. So when a code has a 7th character requirement, but the actual information in the code has 5 or less characters, a placeholder is required. So here's a couple examples of that. I'm bringing back that obstetrical code that we just saw. Here's the 7th character, the 0, and the 060.23 is actually the full specificity of that code, but we have to have that 7th character to indicate which fetus it is, so we have to have an X placeholder. Another example is in the mechanism of injury codes. I have an example from that part of the code set. It's a fall on and from ladder, the initial encounter, that's what the A says, but the A has to be in that 7th place. But the complete information on that code is just indicated with W11. So in order to make sure that the A is in the 7th character, you have to have 3 X's, 3 X placeholders to put the A there. One more item that is new for ICD-10 is the excludes 1 and excludes 2 lists that are in the tabular listing. And excludes 1 means that the items in that list should never be coded with the chosen code, or another way to express that is saying they're mutually excluded. The excludes 2 list says the items in that list, they can be coded with that code, but so they're saying that this code is not, this condition is not described with anything in that excludes 2 list, and if it is applicable, you should code it. So here's an example of a code that has excludes 1 and excludes 2 in its list. I-12 is the code category for hypertensive chronic kidney disease. In the excludes 1 list is included hypertension due to kidney disease, renovascular hypertension, and secondary hypertension. So what that list says is if your patient's condition is an I-12, hypertensive chronic kidney disease, you should not, it's not proper to code any condition utilizing a code from I-15.0 or I-15.1. Actually, and the secondary hypertension is anything in the I-15 category. So the hypertensive chronic kidney disease and secondary hypertension essentially are mutually exclusive to each other. Now, in the excludes 2 list is acute kidney failure, and this is a perfect example of how to understand what this excludes 2 means. Okay, so you can have hypertensive chronic kidney disease. That means you've got chronic kidney disease, but on top of that, your patient could present with acute kidney failure. So, for example, you've got an acute on chronic condition, and sometimes ICD-10 has combination codes that indicate acute on chronic conditions, and sometimes it doesn't. So if you do have an acute on chronic condition and don't have a combination code, often you have to use 2 codes to fully describe that condition, and here's an example of that. Okay, so taking those new things into consideration, we need to look at some pitfalls of common encoder types currently out there on the market. There's two main types of encoders that are currently available. One type is a search-based encoder, and the other is encoder based on a series of questions. So the search-based encoder is just that. It's one advantage of using that is obviously instead of opening up the book, looking in the alpha listing for your condition, and then verifying it with a tabular, you're using a computer to facilitate your search and make it just a little bit faster. And as we all know, again, as I said before, emergency medicine covers the entire spectrum of the code book. So we are, instead of searching 14,500 ICD-9 codes, now we're searching approximately 70,000 ICD-10 CM codes. So using a computer to facilitate that and make it more efficient is important, and there's all kinds of productivity concerns out there. And we want to make sure that we're still coding efficiently. We want to make sure we're coding accurately. So it is helpful to do that, and these are fast if you know how to phrase the search. But some of the drawbacks of these search-based encoders is that you can enter something that's very common throughout a code set, such as fever. And if you type that in all by itself as a search phrase in any kind of search-based encoder, it's going to deliver over 100 results back on that search, which doesn't get you any farther than you were when you started out. So it's going to, and it ends up being pretty much useless. So providing filters is very helpful in that situation. And the other, one of the pitfalls of a search-based encoder is a lot of them, you have to phrase your search exactly right and able to find, in order to find exactly what you're looking for. And this is something that I experienced with the search tool that I used for many years. Physicians never express breast pain as mastodynia. They commonly will say breast pain or mastalgia. And I had to learn fast that if I saw breast pain or mastalgia, I needed to search use mastodynia as my search phrase in order to find the right code to express that. Also, there are different ways to express conditions in ICD-10 as opposed to ICD-9. Lumbago is no longer the way that low back pain is expressed in ICD-10. It's actually described as dorsalgia, pain on the dorsal side of the body. Urination can be described in ICD-10 with the word urination, but it's also described with a nearly synonymous term, which is known as micturition, something that is not commonly used at all. So if you're looking for the code that uses the word micturition, if you're typing in urination, you're not going to find it. Search-based encoders are just that. They are a search only. So they're not going to provide you any direction with sequencing. They're not going to prompt you if additional codes are needed or required, or if they would be helpful in order to provide more information along with your code if they're applicable. The other type of encoder on the market today is an encoder with a series of questions. And so what it does is you type in your patient's condition. It gives you step-by-step guidance through. Where it really shines is when you have a difficult scenario to code, such as sepsis. So you type in sepsis or severe sepsis, and it guides you to the right questions that need to be answered in order to provide all the information that should be coded with that condition. So it's going to prompt you for additional codes. It's going to auto-sequence for you. This is really helpful, especially for a less experienced coder. But one of those drawbacks is also those less experienced coders could be led down the wrong path. If they don't have a good background in anatomy and pathophysiology, they can incorrectly answer those questions, and it can only answer your questions based on what the information you're providing it. Answering those questions can be a time-intensive process, and often it's not unusual to get click-happy, and we'll skip over important items. These types of encoders also do allow direct code entry, but when you do a direct code entry, it's not going to prompt you for additional codes, nor does it auto-sequence for you. So you're just entering codes in, and if you enter them in the wrong sequence or you don't understand those sequencing rules, you're not going to have a properly coded encounter. So with those pitfalls, pros and cons in mind, so let's talk about what you want to avoid. We talked about the pitfalls of some of those encoder types, and we talked about when you enter a search, if you have to phrase it and rephrase it and rephrase it, it takes more time. And again, one of the concerns associated with ICD-10 is that it's going to take longer to apply a diagnosis code to an encounter. So any encoder product that you're looking at, you want to make sure that it enables the coder to express the condition accurately and efficiently. If you're having to rephrase something, that's not efficient. If you're crosswalking from ICD-9 to ICD-10 or from ICD-10 to ICD-9, sometimes that can lead you down the wrong path. I learned that when I was trying to code a mural thrombus. I was looking for that code in ICD-10. I thought, well, let's try and see what ICD-9 has to say about that. And the GEMS mapping from ICD-10 to ICD-9 for a mural thrombus is actually always associates that with myocardial infarction. If you understand what a mural thrombus is, it isn't always associated with a myocardial infarction. So that's not always the right code to describe that condition. Systems that are devoid of prompts, we've talked about that a search will fail to alert the coder when additional code is required, or an encoder product that maybe asks a series of questions but still allows for direct code entry. If it doesn't prompt you to add additional codes or help you sequence them, you can still incorrectly code an encounter. So here's what to look for, keeping all those in mind. You want something that's based on the search and the code. So you talk about advanced search capabilities. Does it have a filter? Is there a way that you can say, well, I'm looking for fever, but I know what kind of the area that I'm looking for, so can I apply a filter to narrow down my search? Does it give you that assistance? And does it help prevent improper code entry? Does it apply to less experienced and more experienced coders? And granted, you can't cover, there's the phrase, you can't make everybody happy all of the time, but you want to have one size fits most. So talking about semantic search, do you have to phrase and rephrase, or we've talked about being able to express a condition in more than one way. So does it have a robust synonym database that helps you find the condition that's described with more than one way? Sometimes, can you find your code with more than one method? Because coders are as unique as they're unique individuals. So they don't all think the same way. So again, if you're trying to have an encoder that is helpful to everyone, you have to help a coder find a code in a different way. And some of them like the series of questions. Some of them use a drop-down where they think more in a hierarchical fashion. And some of them can use the text search and know how to use it effectively. Does it give you a tabular list so you can verify your correct code choice? If you're a coder, you know that when the guidelines state you're supposed to look in the alpha index first, and then you verify that information by looking at the tabular, making sure that that's the way to correctly describe your condition. And we talked about built-in filters to narrow down search results. Is it a symptom? And we're not talking about Q fever, we're just talking about fever as a presenting symptom. Does it assist the coder by prompting for additional codes when applicable or when they're required, or if you know? For example, does it prompt you to add the causal organism of an infection if you know it? And does it help you find that code quickly? Does it add the placeholders for you so you don't have to think, well, okay, W11 has 3 characters, so that means I'm going to have to add 3 placeholders in order to accommodate that 7th character? Does it auto-sequence your codes? So when you're coding sepsis, you remember that your causal organism is always sequenced prior to describing the fact that the patient does have sepsis. Does it help in determining the code for adverse effects or poisoning from drugs? And one of the things that you might look for is, does the coder always have to look up the drug in the table of drugs? Because if you're familiar with ICD-9 or ICD-10, the adverse effects of drugs are listed by the drug type, not the drug itself. So in order to find the right code, you have to look it up in the table of drugs. What if you just type in the name of the drugs and it automatically crosswalks to the correct drug class? That would make your search so much more efficient. Does it prevent improper code entry? So we talked about only allowing complete codes. Does it always prompt you to add that 7th character when it's applicable? And we talked about the placeholders. That's very important so that you can't, I've seen situations where it allowed somebody to code something that didn't go out to the right amount of characters, and so you're not providing it's not actually a code. ICD-10 says it's not a code unless it has the maximum amount of characters. And it also, does it prevent the coding of mutually exclusive items? We talked about that excludes one list. So what if you did try to code secondary hypertension and hypertensive heart disease with chronic renal disease? Does it give you a hard stop and say, no, you're not supposed to do this? These are mutually exclusive. So those are some tips on what to consider when selecting a good encoder product for ICD-10. If you have any questions, we invite all of those, and for further information, we have an email set up just for that at ICD-10@tsystem.com. Again, I'm just so thrilled that you spent part of your day with me, and I'd invite any questions that you have based on the information that we presented today.
Thank you, Elizabeth. So as she mentioned, we do have a few minutes left over for Q&A, so go ahead and submit that in the Q&A section. We do have one question that's come in so far. It says, so our facility uses super bills for procedures and diagnosis. Why can't we continue to use those?
That's an excellent question. That's a common practice in ICD-10 or ICD-9 today. And it happens in departments and facilities. It happens in physicians' office because if you think about it, ICD-9 has about 14,500 codes. But if you expand that to about 70,000 codes, and even if you're talking about a single specialty, the expansion of the code set is just, it's so massive in some places that either you have to make your print super small on your super bill, or it has to be multiple pages, and it becomes, again, like when you enter a search phrase of fever, it produces such a huge result on your search, it's useless. So if you've got in order to accommodate ICD-10 on your super bill, your options are going to start being impractical. So you might want to consider some kind of an actual encoder tool to make your coders work more efficient and more accurate.
Great, thank you. Well, it looks like that's all the questions that we have right now, but We'll hang on the line just for a little bit longer in case anyone wants to submit one. But I just want to thank you again for taking the time today for this webinar. And like I said, we have recorded the session, so I'll be sending that out at the end of the session. Thank you, and we hope you'll join us again for our next webinars.